Good evening, everyone. I'm audible and visible to all of you guys. Please write down in the comment section. Good evening. Good evening, everyone. I'm audible and visible. So I hope all of you are doing great. We are just 9 days away from the exams, and I'm sure that all of you are confident enough to get this exam done. So welcome to the session, guys. So without any further delay, let's begin with the first question of the day. So we are going to have a crisp and concise revision of an PSM. So all the things that you remember to the related topic, you are most welcome to write down in the chat box. Okay. So let's make this session more interactive. So everything you know about the related topics, write down in the chat box, and so that this session helps you all in the active recalling. Okay. So let's begin, guys, with the first question of the day. A government of India started Anemia Mukt Bharat program. And what is the dose of the iron folic acid tablet for the adolescent girl? What is adolescent? Around 10 to 19 years. So around 10 to 19 years of age, as per the Anemia Mukt Bharat, what is going to be the dosage for the iron and folic acid? Write down in the chat box. Now, first thing, sir, this Anemia Mukt Bharat program, it was launched which year? 2018. This program was launched in 2018, and the main goal of this program was to decrease the prevalence of the anemia, to decrease the prevalence of anemia by 3% every year, to decrease the prevalence of the anemia by 3% every year. Okay, now as per this program, we have a strategy called as 6x6 strategy. So write down in the chat box what exactly is 6x6 strategy. I'm getting the answers, sir. B, everyone. That's the first silly mistake you guys are doing, guys. The age group is 10 to 19. I know every time they have asked in case of pregnancy and lactation. But in the recent NEET PG, they have asked the adolescent. So what will be the dosage for the adolescent? It's not daily. Yes, it is. The dosage is the same, 60 mg of iron, 500 micrograms of folic acid, but the frequency is going to be the weekly. Okay, that's the first silly mistake you guys are doing. Make sure read the question properly. Okay, whether are they asking a question from a pregnancy, lactation, or a adolescent? So what is going to be the answer for this particular question, guys? It's 60 mg of iron, 500 micrograms of folic acid weekly. Clear to everyone? Yes. Now, sir, we have 6 beneficiaries, 6 interventions, and 6 institutional mechanisms. Okay. The first very question again, 6x6 strategy is for Anemia Mukt Bharat. Number first question, what are exactly these 6 beneficiaries? So we have an age group from 6 months to 5 years. So the iron dosage is going to be 20 mg. Folic acid is going to be 100 micrograms. And the frequency is twice a week. Okay, followed by that, the age group of 6 years to 10 years, we have a dosage of iron 45 mg, and the folic acid is going to be 400 micrograms, and the frequency is weekly. Followed by that, the adolescent age group 10 to 19 years, the dosage for the iron is going to be 60 mg of iron. Folic acid is going to be 500 micrograms of folic acid, and the frequency is going to be again weekly. Followed by that, 19 years to 49 years, the reproductive age group, we have 60 mg of iron. We have folic acid of 500 micrograms, and again it is going to be weekly. Now, sir, pregnancy and lactation. Yes, you already know this has been the previous year question and asked multiple times in your exams. That's going to be 60 mg of iron, 500 micrograms of folic acid, and the frequency is going to be daily. How exactly to differentiate? You already know the color of the pills is red color, pregnancy and lactation, blue color, 19 to 49 years, and the pink color, 10 years to 19 years. Is that clear to everyone? Yes. Now tell me, what exactly is 6x6 strategy? 6 beneficiaries, 6 institutional mechanisms, and 6 interventions. Okay. Now one more question that they can ask, as per the 6 interventions, we have to deworm the patient also with an albendazole. Now can you tell me which worm can cause iron deficiency anemia? Write down in the chat box. Which worm will cause iron deficiency anemia? The answer is going to be hookworm. The answer is going to be hookworm. Okay. And which worm can cause this? Which worm can cause the megaloblastic anemia? Which worm can cause the megaloblastic anemia? Your answer is going to be fish tapeworm. What is the answer? So it's going to be fish tapeworm or diphyllobotham latum, D latum. Is that clear to everyone? Yes. Now you already know that this megaloblastic anemia, let's integrate this session. Okay. This megaloblastic anemia can cause, this can be due to the both B12 deficiency as well as B9 deficiency. But how to differentiate through the symptoms? If a patient is having a neurological deficit features, it's going to be B12. But as per the investigations, you are going to check the MMA levels and homocysteine levels. If both of them are elevated, it's going to be B12 deficiency. If MMA levels are going to be normal, it's going to be B9 deficiency. That is going to be folic acid. Is that clear? Is that clear to everyone? Yes. Now, sir, how much of folic acid to be given to a lady who had a history of a neural tube defect? Remember that if a patient is having the history of a neural tube defect like spina bifida or anencephaly, the dosage for folic acid is going to be 400 micrograms per day. The dosage is going to be 400 micrograms per day. So make sure if a question asks how much is the dosage of iron as per the Anemia Mukt Bharat, as per the given logo, as per the given program, the dosage of the iron is going to be the 60 mg. But if the question asks generally directly how much of iron needs to be given in a pregnancy, then the answer is going to be 100 mg per day. Answer is going to be 100 mg per day. Is that clear? Is that clear to everyone? Can I move to the next question, guys? Chalo. A 24-year-old sexually active female presents with a single painless genital ulcer of 7 days duration. There are no vesicles, no history of the similar episodes in the past, and no systemic symptoms. On examination, the ulcer has clean margins and a firm base. There is no history of penicillin allergy. Now, based upon a syndromic management of sexually transmitted infections, which STD color-coded kit should be used? Now, it's a question from the Suraksha Clinic. The Suraksha Clinic is having a syndromic approach to the patients. What exactly is the syndromic approach of the patient? So that means the treatment is given based upon the symptoms, not on the basis of the diagnosis. Okay. Now, each symptom have a particular kit that has to be given under this Suraksha Clinic. Okay. And this is a service for the sexually transmitted infections or reproductive tract infections. Okay. Now, sir, the first question that they have asked is, the patient is coming to you, patient is having a genital ulcer. Yes. Followed by that, it's mentioned that the ulcer has clean margins and a firm base. So if you remember from the kits, okay, some people are answering it's micrograms instead of 400. If a patient is having history of neural tube defect, then only you are going to give 4,000 micrograms. Okay. Yes. So if a patient is coming with the complaints of a genital ulcers, okay, we already know that for the genital ulcers, we are giving 3 kits. First kit is going to be white, blue, and red. So what was the sequence? It was white, blue, and red. Okay. Now, sir, white kit I'm giving for the genital ulcers, which are non-herpetic, but they are responding to penicillin. So that is white. Blue color I'm giving for the genital ulcers, non-herpetic, but they are allergic to penicillin. And red color I'm giving for the genital ulcers which are herpetic. Okay. So which of the following kit you will give from the options? Now, this patient, he has no history of penicillin allergy. First thing, there are clean margins and firm base, which are suggestive of a non-herpetic genital ulcer. So this is a non-herpetic genital ulcer. This is a non-herpetic genital ulcer and it is responding to penicillin. It is responding to penicillin. So which of the following kit you are going to use? Write down in the chat box that the answer is going to be kit 3 white. Answer is going to be kit 3 white. Clear to everyone? Yes. Now let's discuss all the color coded kits. Now we have 8 kits and based upon the symptoms, we are going to prescribe each kit. Now, first very kit, that is kit 1 gray. And tell me, what are the symptoms you will prescribe the kit 1 gray? Any patient coming to you with the complaints of a urethral discharge, patient coming to you with the complaints of a urethral discharge, or patient complaints of cervicitis, patient complains of cervicitis, or patient is having painful scrotal swelling. There is painful scrotal swelling. Your answer is going to be, what is the kit? Your answer is going to be kit 1 gray. Your answer is going to be kit 1 gray. Okay, before 1 year the anorectal discharge was also included. Before 1 year the anorectal discharge was also included in kit 1 gray, but now it is included in the kit 8 brown. Now it's included in the kit 8 brown. Okay, followed by that, sir, if a patient is coming with the complaints of a vaginal discharge. Now based upon the vaginites you have studied, okay, now sir, any patient complaining of a vaginal discharge, now you know on the basis of the vaginal discharge, it's a creamy discharge, your answer is going to be the bacterial vaginosis. If it is a greenish discharge, your answer is going to be the trichomoniasis. And if it's a curdy or a cheesy discharge, your answer is going to be the candidiasis. But as per the syndromic management for the Suraksha clinic, any patient coming to you with the complaints of a vaginal discharge, you are going to give which kit? Green color kit. Okay, green color kit. So for vaginal discharge, you're going to give the green color kit. Very good. Followed by that, kit 3, white, blue and red. Okay, if you remember, can you tell me the white, blue, red? This has been also asked in your medicine. White, blue, red, it's a discoloration sequence for which particular condition? And what is going to be the treatment for that particular condition? White, blue, red, it's going to be the discoloration sequence for which particular condition? And what is going to be the treatment for that condition? They can give an image-based question of the fingers and ask. Yes, very good. It's going to be Raynaud's phenomena, and treatment is calcium channel blockers, and the treatment is going to be calcium channel blockers. Now sir, we already know that. The white color kit, it is for the genital ulcers which are non-herpetic, and sir, they are responding to the penicillin. They are responding to penicillin. They are, I will just write in short, they are responding to penicillin. Okay, blue color, the same one, it is for genital ulcers. So again, they are going to be non-herpetic. Again, they are going to be non-herpetic, and these ulcers are allergic to the penicillin, or you can write resistant to penicillin. So if the same question would have mentioned that there is a history of penicillin allergy, what will be your answer, guys? If the same question would have mentioned that there is a history of allergic to the penicillin, your answer then goes to kit 4 blue. Your answer then goes to kit 4 blue. Okay, followed by that, red color. So red color is genital ulcers. Red color is going to be genital ulcers, and they are herpetic. They are herpetic genital ulcers. Followed by that, any patient complains of a lower abdominal pain. Any patient complains of a lower abdominal pain, sir, or PID, the kit that we are going to prescribe is kit 6 yellow color. Okay, followed by that we have black color kit. Black color kit for inguinal bubo, or we have inflamed lymph nodes. Inflamed lymph nodes, that is going to be kit 7 black. And followed by that, any patient complains of anorectal discharge. Anorectal discharge, your answer is going to be kit 8 brown. Your answer is going to be kit 8 brown. So that's all about the color coded kits under the Suraksha clinic. And what exactly is this Suraksha clinic, sir? This Suraksha clinic is giving a syndromic approach to the patients, and the services they give are sexual transmitted infection or reproductive tract infection services. Now, one more question that they can ask is, what exactly can be the medications inside these kits? Now, for example, if a question has been asked that a patient complains of a urethral discharge or a patient is having a gonococcal urethritis, what are the medications inside the kit? Now, tell me fast, what can be the medications in these kits? Okay, can you tell me what are the medications inside the gray color kit? Tell me first, what are the medication inside the gray color kit? So for the gray color kit, the medications inside are, I will write here, it is going to be azithromycin plus cefixime. Okay, then for the green color kit, so we have secnidazole and fluconazole. Secnidazole and fluconazole. So white color kit, you already know that we are giving penicillin. So we have azithromycin plus penicillin. Azithromycin plus penicillin. So blue color kit, penicillin is resistant. So I'm going with doxycycline and azithromycin. I'm going with doxycycline plus azithromycin. Okay, for red color kit, you already know herpetic genital ulcers, I'm giving a red color kit. For kit 6, yellow color, it is a PIDK, so we are giving 3 antibiotics: DCM, doxycycline, cefixime and metronidazole. Followed by that, for black color, we have again azithromycin and doxy, and for brown color, we have doxy and cefixime. Is that clear? Is that clear? So that was all about the Suraksha Clinic and the color coded kits. That was all about the Suraksha Clinic and the color coded kits. Can we move to the next question, bache? Yes, sir. Chalo. Next question. A 45-year-old man with a 10-year history of smoking visits a health camp. He has no respiratory symptoms. He's advised to stop smoking and is counseled regarding the lifestyle modification to prevent the development of a COPD. Which level of prevention it is? Yes, acyclovir 400 mg and it's given for the 21 days. Okay, don't go for the fully dosage, but at least do remember the medications inside these kits. Now the next question is from the level of preventions. I've included the questions that examiner usually asks. Okay, now the examiner has asked the question, the 10-year history, a patient has a smoking history of 10 years and now he's being counseled that you should not smoke anymore because you can have a COPD. Now, which type of prevention is this? Which type of prevention is this? Is it a primary prevention? Is it a secondary prevention? Is it a tertiary prevention? Or it is a primordial prevention? Or it is a primordial prevention? Write down in the chat box, everyone. Which type of prevention is this? Now see guys, we have 2 phases. We have pre-pathogenic. We have pre-pathogenic phase. Okay, and we have pathogenic phase. We have pre-pathogenic phase and we have pathogenic phase. Okay, when we talk about pre-pathogenic phase, okay, in pre-pathogenic phase, that is before the disease. So before the disease, we have 2 preventions. Either we go for the primordial prevention, okay, or either we go for a primary level of prevention, or either we have a primordial level of prevention or we have a primary level of prevention. So in pathogenic, okay, we have early secondary or late tertiary. So we have either secondary level of prevention or so we have tertiary level of prevention. Okay, simple meaning you have to understand. So when we talk about the first level of prevention, that is going to be the primordial level of prevention. That is going to be the primordial level of prevention. So what exactly is a primordial level of prevention? It means when you are trying to stop the risk factor to occur. Okay, so it is a prevention of, so it is a prevention of occurrence of risk factor. It's a prevention of occurrence of risk factor. Okay, for example, a classical example that I've usually mentioned in the main classes as well. If you are changing the water of the cooler every week, so no mosquitoes are going to come around the water. So eventually no mosquito is going to enter in your room and bite, and eventually you're not going to have a malaria. Now, if I'm changing that water every week, So I'm trying to stop the risk factor to occur. I'm trying to stop the mosquitoes to come near the water. Now mosquitoes came. Now I'm using the mosquito nets in order to prevent myself from the disease. So risk factor is present now and you're trying to stop the disease to occur. That is going to be the primary level of prevention. And now further, the mosquito bite and you went to the hospital, you are going to have a histidine rich protein test and you are going to have an LDH test. Okay, all those investigations, that is the early diagnosis and treatment. That is going to be the secondary level of prevention. Okay, and followed by that, disease complications, you're going to have a tertiary level of prevention. Is that clear? Now let's, in this particular question, it was mentioned that patient is having a history of smoking. Patient is having a history of smoking. That means risk factor is already present. Now we are telling him that regarding the lifestyle modification, you need to prevent the development of the COPD. So we are trying to stop the disease to occur in presence of the risk factor. This particular type of prevention is going to be primary level of prevention. Is that clear to everyone? Yes, clear to everyone? What exactly is a primary? What exactly is a secondary? What exactly is tertiary? And what exactly is primordial level of prevention? Okay, now chale. Now sir, prevention of the occurrence of risk factor, that is going to be the primordial, and it is in which phase? It is pre-pathogenic. Sir, it is going to be pre-pathogenic. Okay, next one is going to be the primary level of prevention. So primary level of prevention means that we have a prevention of disease. We have a prevention of disease in presence of risk factor. In presence of risk factor. Okay, again this is going to be the pre-pathogenic phase we have earlier discussed. Okay, followed by that we have secondary level of prevention. Okay, what exactly is the secondary level of prevention? So it means early diagnosis and treatment. Early diagnosis and treatment. Okay, and the phase is early pathogenic, early disease. Okay, followed by that we have next one, that is going to be the tertiary level of prevention. And tertiary level of prevention, there is a management of complications. There is a management of complication and disability. And it is going to be the late pathogenic. It is going to be the late pathogenic. Clear to everyone? Yes, it is going to be the late pathogenic. Now, classical example, clutchers in the polio. Okay, that is a classical example of a tertiary level of prevention. Okay, now my first question to you guys. Okay, is that clear to everyone? What exactly is a level of prevention? Yes, what exactly is a level of prevention? That is going to be primary. Okay, okay, now sir, you have a patient. Okay, and as per the complications which occur in the third stage of the labor, we are giving oxytocin as per the active management of third stage of labor. So giving oxytocin in active management of third stage of labor is a which level of prevention? As per the AMTSL, you are giving an oxytocin. What exactly is the level of prevention? Answer me in the chat box. What exactly is the level of prevention? Giving oxytocin as per. Sir, BCG vaccine in bladder cancer is a what level of prevention? That is going to be the secondary level of prevention. All the vaccines are primary level of prevention, but BCG vaccine in case of bladder cancer, you are using it as a treatment. So treatment is going to be secondary level of prevention. Okay. My question was using oxytocin as per active management of third stage of labor. So as per active management of third stage of labor, you're using this oxytocin for the prophylaxis. They have studied in the OBGY also. Okay, you're giving 5 to 10 units in order to prevent the PPH to occur. So any treatment for the prophylaxis is going to be the primary level of prevention. Okay, but yes, if the PPH occurred and you are giving the oxytocin, then the treatment is going to be the secondary level of prevention. It's going to be the secondary level of prevention. Clear to everyone? What exactly is a primary and secondary? One more example now. Tell me, you have a patient. Okay, mother. Okay, mother is HIV positive. Mother is HIV positive, okay, and mother is already on the ART, and now the new baby born, baby is healthy, and we started prophylactic drug nevirapine and zidovudine. We started two drugs because the viral load was too much, so nevirapine and zidovudine. So this nevirapine and zidovudine in baby is which level of prevention? Nevirapine and zidovudine is which level of prevention in? Yes, it's a which level of prevention? Using nevirapine and zidovudine in newborn prophylaxis, it's a which level of prevention? Very good, excellent. So it is going to be the primary level of prevention. Are you getting my point? Risk factor is present. Mother is HIV positive. That is present. But now we are trying to stop the disease to occur in the baby. So baby ke liye we are giving two drugs, that is nevirapine and zidovudine. Okay. If low risk, we are giving nevirapine only 6 weeks. If high risk, we are giving nevirapine and zidovudine for the 12 weeks. Again, the NEET PG PYQ. But make sure you remember one thing in this particular question where the examiner will be smarter enough. He will mention that mother was already on the ART, but the viral load is more than 1000 RNA copies per ml. So when it is more than 1000 RNA copies, it directly goes to the high risk. Doesn't matter if the mother is on ART or not, irrespective of that. If the RNA copies are more than 1000, it's a high risk. And then for that particular condition, you're going to give a two drugs, nevirapine and zidovudine for the 12 weeks. And if mother is on ART with the RNA copies less than 1000, then it's going to be the only one drug because it's a low risk. Chale, clear? Clear everything about the level of prevention? Yes? Chalo. Now tell me the following examples for vaccines. I just said vaccine is going to be the primary level of prevention. But yes, if a patient is complaining of a painless hematuria or a history of working in a dye industry with a bladder cancer, classical case, painless hematuria, okay, and sir, then the BCG vaccine is used as a treatment. So that particular level of prevention is going to be the secondary because we are using it as a treatment. Okay, pap smear for the cervical cancer, it's a screening test. Okay, early diagnosis, it is going to be the secondary level of prevention. Followed by that mammography. सर ऑक्सीटोसिन तो डायग्नोज करने के बाद ही देंगे ना AMTLS में? नहीं the what is a aspirin toxicity? Listen, I said active management of third stage of labor. What is active management of third stage of labor? You are giving oxytocin. Okay, we have 4 steps in active management of third stage of labor. We have 4 steps. First step, we are giving a uterotonic agent, okay, oxytocin. Then we have delayed cord clamping. Then we have the delivery of the placenta, and then we have assessment of the uterine tone. Now, why I'm going for the active management of third stage of labor? Because I want to stop the complications which occur due to that particular stage. So what can be these complications? It can be the postpartum hemorrhage, it can be the uterine inversion, it can be shock, embolism, all those things. Now, if I'm giving a prophylactic drug, the first step of the AMTSL is giving a drug oxytocin, 5 to 10 units. Okay, so I'm trying to stop the PPH to occur. I'm trying to stop these complications to occur. So as per AMTSL, this is going to be the primary level of prevention. But अगर PPH हो गया है, उसके बाद आप oxytocin दे रहे हो, then it is going to be the treatment, secondary level of prevention. Is that clear? Aspirin toxicity. Is that clear to you? चले आगे बढ़ते. Now, sir, mammography is a screening, guys, going to be the secondary level of prevention. सिंपल सी बात है, जो भी प्रोफाइलेक्टिक के लिए आप यूज करते हैं, दैट इज गोइंग टू बी द primary level of prevention. ठीक है, change of water in the cooler every week, just now we have discussed that it is going to be the primordial level of prevention. Followed by that, use of the mosquito nets. Mosquito present है, risk factor present है, and you are trying to stop the disease to occur, that is going to be again the primary level of prevention. And in the same case, अगर patient जा रहा है for the peripheral blood smear or patient is going for the histidine rich protein, then it is going to be the secondary prevention. Next question, a 14-month-old child is brought to a primary health center for immunization. The mother reports that the child has never received any vaccines. So it's a classical question from the delayed vaccination schedule. Okay, now child is coming 14 months and child has not received any vaccine so far. The child is clinically stable, okay, and has no contraindications. As per the national immunization schedule, which of the following is the most appropriate immunization plan at the first visit? Now, as per the national immunization schedule, which of the following is the most appropriate plan for the first visit? Now, if you remember from the delayed vaccination schedule, okay, we have vaccines. Now, you already remember that BCG, RVV, IPV, PCV, and pentavalent first dose. These all vaccines can be given up to 1 year only. So these all vaccines can be given up to 1 year. They can be given up to 1 year. Is that clear? So what are the vaccines which can be given up to 1 year? So we have BCG, RVV, IPV, PCV, and pentavalent first dose. Okay, talking about pentavalent second and third dose, so that can be given up to 7 years. That can be given up to 7 years. Followed by that, DPT, that can be also given up to 7 years. That can be also given up to 7 years. Followed by that, we have PCV. I've just mentioned the PCV earlier again, so it's up to 1 year. We have OPV, MR, or MMR, so that can be given up to 5 years. That can be given up to 5 years. And Japanese encephalitis, it can be given up to 15 years. It can be given up to 15 years. Now tell me what exactly has the question asked. Question is asked that you have a 14-month child. So child is coming, it's more than 1 year. So which of the following is the most appropriate immunization? So you already know one thing for sure, that BCG can be given. So BCG can be given up to 1 year. So in the option A and option C, you already have a BCG. So you already know that you can give BCG up to how long? So BCG up to 1 year. So it's more than 1 year. It's more than 1 year. It's 14-month child. Now you already know that BCG you cannot give. So option A and option C is ruled out. Followed by that, you also know that the pentavalent first dose can be also given up to how long? Can be also given up to 1 year. So again, the option B is not the appropriate plan. So what is going to be the answer? So OPV first dose we can give, DPT first dose we can give, and measles first dose we can give. So answer is going to be option D. Clear to everyone? Yes. Again, it's not the option B. Why? Because in option B there is a pentavalent first dose bache, and pentavalent first dose can be given up to 1 year only. So the proper plan for the first visit for this baby is going to be OPV first dose, DPT first dose, and measles first dose, Clear? Is that clear to everyone? Yes. Chale. Next one, so universal immunization program. Jaldi se. Sir, at birth, what are the vaccines we give? At birth we give Bob. Sir, what is Bob? Bob is not a vaccine, it's hepatitis B. Plus we give OPV. Plus we give BCG. So at birth, what are the vaccines given? We are giving Bob, hepatitis B, OPV, and BCG. Now around 6 weeks, 10 weeks, and 14 weeks. At 6 weeks, we are giving DPT 1. We are giving OPV 1, we are giving Hep B 1, and we are giving Hib 1, and we are giving Rota 1. Or you can also write pentavalent, that is DPT plus Hep B plus Hib, that is pentavalent, along with that Rota and OPV 1. At 10 weeks, you are giving DPT 2, you are giving OPV 2, Hep B 2, Hib 2, and we are going for Rota 2. Okay, followed by that, at 14 weeks, we are going for DPT 3, OPV 3, Hep B 3, Hib 3, and Rota 3. Okay, followed by that, around 9 months, we are going for Japanese encephalitis, and we are going for MR. Also at 9 months, we usually go with a vitamin A. Okay, followed by that 16 to 24, we are giving OPV booster, we are giving DPT booster, and we are giving Japanese encephalitis 2, and we are giving MR2. Followed by that, around 5 years, we are giving DPT booster 2. Okay, around 10 to 16 years, we are giving tetanus plus diphtheria, TD. Okay, and in pregnancy, you already know that one particular thing. In pregnancy, आपको पता है कि yes, if talking about the tetanus in the pregnancy, sir, if it's a primary gravida, we are giving 2 doses. The first dose as soon as possible, second dose, third 3 weeks prior to the estimated date of delivery. But if she's a multi-gravida with a last childbirth, within 3 years, you are giving 1 dose, and last childbirth more than 3 years, again you are going to give the same 2 doses. Is that clear? That's all about the vaccines. Okay, go through the side effects of vaccines as well and strains plus minus. Chalo, next one. A patient from different age group from a village in West Bengal came to the clinic with an illness. On examination, it is noted that all of them were having the edema. On history taking, it was found that they were consuming the mustard seeds which are bought from the same local shop. Okay, what is the most probable diagnosis? What is going to be the diagnosis for this particular condition, guys? Or what is the most likely toxin responsible? So tell me toxin as well as tell me the diagnosis as well. Tell me the toxin as well as the diagnosis. What is going to be the toxin and the diagnosis? Write down in the chat box. Yes, sir. The answer is option D. Very good. Sanguinarine. Yes, it's a toxin responsible for which food adulteration disease? It's a toxin responsible for which food adulteration disease? So it is going to be the case of epidemic dropsy. It is going to be the case of epidemic dropsy. Okay, and the toxin associated is sanguine, and the foodstuff is mustard, okay, and the agent is argemone mexica oil or argemone seed. Is that clear? Is that clear? Now let's discuss what exactly are these food adulteration disease. All the questions that I have asked so far with the related topics, they have been asked multiple times. Okay, now sir, in the food adulteration disease, the first one we have, can you tell me other options? BOA toxin, beta oxalyl aminoalanine. This toxin is for which particular food adulteration disease? That is going to be lathrism. Okay, followed by that aflatoxin. It's a toxin. Groundnuts food adulteration disease is aflatoxicosis. Food adulteration disease is aflatoxicosis. Followed by the pyrrolizidine. Okay, the disease is going to be the endemic ascites. The disease is going to be the endemic ascites. Then sanguine, you already know that it is going to be the epidemic dropsy. It is going to be the epidemic dropsy. Okay, now either the examiner will ask the toxin as responsible, or either the examiner can ask the foodstuff, or either the examiner will ask the diagnosis. Okay, now based up on the disease, the first one we have lathrism. Now sir, the toxin responsible for lathrism is BOA. Okay, what is BOA? Beta oxalyl aminoalanine. The agent is kesari dal. The agent is kesari dal. Okay, and the food stuff is yellow pulse. And the food stuff is yellow pulse. Okay, number first one. Number second, the disease, it's epidemic dropsy. For the epidemic dropsy, bache, what exactly is the toxin? It is sanguine. Okay, agent, it's argemone seed. Followed by that, the food stuff is mustard. Food stuff is mustard. And this toxin, which is sanguine, it causes the increase permeability, capillary permeability, which increase the edema. That's why examiner has mentioned in the question that they were consuming mustard seeds and all of them were having the edema. All of them are having edema. So edema is a classical feature of, okay, edema is a classical feature of the which particular condition? Epidemic dropsy. So write the symptoms of clue also, please? Yes, I'm going to mention the clinical features as well, so that every clinical feature you are seeing, you will right away answer what exactly is the toxin and what exactly is the disease. Followed by that, we have one more, that is endemic ascites. We have endemic ascites. Okay, now endemic ascites, the toxin is going to be pyrrolizidine, and the foodstuff agent is going to be corotorella seeds, and the foodstuff is going to be millet. Foodstuff is going to be millet. Okay, next one, it's going to be aflatoxicosis. It's going to be aflatoxicosis. The toxin is going to be aflatoxin. Okay, and then we have the agent, that is going to be Aspergillus flavus, and the foodstuff is going to be groundnut. Foodstuff is going to be groundnut. Followed by that, we have ergotism. The toxin is going to be ergot alkaloid. And the agent is going to be claviceps fusiform. For purpura, claviceps fusiform. And the foodstuff is going to be flowering plants like wheat. So that is all about the toxin and the foodstuff. That is all about the toxin and the foodstuff. Now, first question, they are not directly going to ask you what is the toxin responsible for this particular disease. So rather they will mention some symptoms. Okay. Now, based upon the clinical features of these food adulteration disease, number first one is letharism. Remember, whenever an examiner will ask, the patient is not able to walk, there is gait instability. Are you getting my point? Now you are thinking of osteoparalysis. You are thinking of osteoparalysis, and this classical image is the osteoparalysis, and osteoparalysis or neuroparalysis. Osteoparalysis and neuroparalysis. This is a feature of which particular food adulteration disease? Letharism. This is a feature of which food adulteration disease? Letharism. Next one is going to be the epidemic dropsy. You just see the patient is having edema due to the increased capillary permeability. Followed by that, we have patient can have vision problems, glaucoma. Followed by that, patient can have a cardiac failure. Patient can have diarrhea as well, or patient can have dyspnea as well. So these all are the features of which food adulteration disease? Epidemic dropsy. And this epidemic dropsy is the previous year question twice asked in your exams. Okay. Followed by that, there is a veno-occlusion disease of the liver, which will eventually cause the failure of the liver. Patient will have a jaundice. And followed by that, liver failure, you know, that is the most common cause for the ascites as well. So any patient complaining of an abdominal distension, that means there is ascites, along with that increased liver enzymes, that is jaundice. So jaundice and ascites. Jaundice and ascites are going to be the feature of which food adulteration disease, bache? That is going to be the feature of a endemic ascites. Okay, so abdominal distension, then increased liver enzymes, jaundice, pale skin, these are going to be the features of the endemic ascites. Okay, and also sir, if they ask about aflatoxicosis, aflatoxicosis के साथ याद रखेंगे आप लोग that it is related to the hepatocellular carcinoma. So if HCC is given in the hint, or increase alpha fetoprotein is a marker, AFP positive is given in the hint, so you are thinking of an aflatoxicosis, and the toxin is aflatoxin. And followed by that, if there are vasospasm, gangrene-like features, if the classical case is mentioned, along with that, it is mentioned that there is a pulseless activity, okay, over the fingers, there is no history of smoking. Why? They will give the gangrenous picture with no history of smoking, so that you can rule out the thromboangiitis obliterans as well. Okay, na? So they will give the history that there is no smoking history, okay, pulseless activity, gangrenous fingers. So you are thinking about the ergotism. So vasospasm gangrene is a feature of an ergotism. So this is all about the classical symptoms of the food adulteration disease. Okay, they don't ask if you go with the previous year questions back 3 years before or 4 years before. Simple: toxin responsible for epidemic dropsy, toxin responsible for the aflatoxicosis. But now the question that they ask, bache, that is along with the classical features. So they will give the features, you have to diagnose the features, and then you have to answer the toxin. Now, so what is the way to prevent and control such things? So we will removal of the toxins. So removal of toxins by steeping method, by steeping and parboiling method. By steeping and parboiling method. Number first. Number second one, so we can start the vitamin C prophylaxis. So we can start with the vitamin C prophylaxis, or so we can ban the crop. We can ban the crop. Followed by that, or we can aware or educate people. We can aware or educate people about the disease. That's how we can prevent or control such disease. Is that clear? So that is all about the food adulteration disease. So make sure, have a quick recap what exactly I've said. That first one, so lathyrism, osteoparalysis and neuroparalysis are the features. Gait instability will be mentioned, and the toxin is beta oxaloaminoalanine, that is BOAA. Followed by that, epidemic dropsy, features of the glaucoma, vision problems, cardiac failure, along with that bilateral edema of the legs. Okay, they all goes with the epidemic dropsy, and the toxin is going to be the sanguine. Followed by that, increased liver enzymes with abdominal distension, jaundice and ascites, that is going to be the endemic ascites, and the toxin is going to be pyrrolizidine. History of the groundnuts, and then followed by that there is an aflatoxin, hepatocellular carcinoma, that is aflatoxicosis. Features of the vasospasm gangrene, pulsus activity of the fingers, black gangrenous picture given, that is going to be ergot, alkaloid and ergotism. Is that clear? So that's all about the food adulteration disease. Remember, kesari dal, yellow pulse, groundnut, millet, mustard and flowering plants. Clear? Next question of the day. Epidemiology is the study and the analysis of the distribution patterns and the determinants of health and disease. Okay, now which among the following correctly defines the generation time in the epidemiology? So this generation time I have seen a lot of times, so these definitions are important as well. So which among the following defines the generation time? Write down in the chat box, which among the following defines the generation time? Which among the following defines the generation time? Which among the following defines the generation time? Yes, write down in the chat box. Interval between the marriage and birth of the child, it's not the one. Yes. Option B, interval between the entry of organism till the maximum infectivity. Very good. Yes, so write down the answers of A, B, C and D. Write down the answers of A, B, C and D. What exactly is the interval between the marriage and the birth of the child? So we have phases of the family cycle, and that is going to be the formation, sir. That is going to be the formation. Followed by that, interval between the entry of organism till the maximum infectivity. Very good, sir. That is going to be the generation time. Followed by that, interval between the primary and the secondary case. That is going to be the serial interval. That is going to be the serial interval. Okay, that is going to be the serial interval. And the interval between the entry of infectious agent and the symptoms of disease, that is going to be the incubation period. That is going to be the incubation period. Is that clear? So what exactly is the answer for the generation time? That is option B. That is going to be option B. Now can you tell me, bache, that interval between the entry of infection till the detectable antibody present, what is the answer? till the detectable antibody present. So the answer is going to be window period. We call that period as a window period. Then you already know that what exactly is a primary case. It is going to be the first case of the disease. What exactly is the secondary case? It is going to be the case developed from the contact of the primary case. Okay, then you have two more definitions. We have quarantine, and so we have isolation. We have quarantine, and so we have isolation. Okay, what is quarantine? So quarantine is there is a separation of the healthy people till the incubation period. I'm writing IP, so you have a hint. Quarantine is separation of the healthy people or suspected people till the incubation period. Okay, what exactly is the isolation, bache? So isolation means the separation of a diseased person till the period of infectivity or till the period of communicability, till the period of infectivity or till the period of communicability. Is that clear? Is that clear? Yes, all these definitions are clear. Yes, what exactly is formation, what exactly is the generation time, and what exactly is the primary and secondary interval, the serial interval, what exactly is the incubation period, what exactly is window period, quarantine and isolation. Okay, so for example, for COVID-19, 14 days is the quarantine period. Okay, is that clear? For a period of communicability of the measles, 4 days before the rash, 5 days after the rash. So the isolation is 4 days before the rash and 5 days after the rash, because at this particular time it can communicate to the others. Clear? Next question. A couple got married in 2018 and gave birth to the first child in 2020. The couple has given birth to their second child in 2022. Okay, shadi beginning. Are you getting my point? Family phase ka beginning hai, that is the formation. So from the birth, marriage to the birth of the first child, that was the formation. Now their second child was born in 2022. Okay, now in 2025, when the surveyor went for the data collection, it was told to him that couple are planning for another child. Now it's not the last child, they are still planning one more child, that is going to be their last one. So the family is in which phase? Okay, is the family in an extension, complete extension, contraction, complete contraction? Now tell me, family is going to be in which phase? So sir, we have phases of family cycle. So from the marriage to the birth of the first child, it is going to be the formation. So that's what we have discussed here. Marriage and birth of the first child, it's going to be the formation. Followed by that, from the birth of the first child till the birth of the last child. So there the examiner has asked that their first child was in 2020, second child was in 2022. So 2025 he is going, and they are saying that we are still planning the next child. Okay, so they are in which phase? They are in which phase? How come it will be contraction? है ना, contraction तो होगा नहीं, complete extension भी होगा नहीं. Okay, let me define first. Okay, now if you see that phases of the family cycle, you all know they are not ever changing, they are not constant. Okay, first one was the formation, sir. Clear tha formation, marriage se leke birth of the first child. Okay, now extension is birth of the first child till the birth of the last child. Now it's not two childs only, so from the first one till the end, the last one. So now here the couple 2020 mein first child, second child 2022 mein, they are planning the next one. Okay, it can be 2026, but right now they are in the which phase? From first till the last child, so it goes with a extension. They are in the which phase, bache? They are in the which phase? They are in the which phase? They are in the extension. Now from the further birth of the last child till the first child leaves home, that is going to be the complete extension. First child leaves home and the last child leaves home, that is going to be the contraction. Last child leaves, the first spouse dies, that is complete contraction. First spouse dies and the death of the survivor, that is going to be the dissolution. So in the given clinical scenario, in the given clinical question, it was mentioned that they are planning the next child as well. So they are particularly currently in which phase? Extension. Next question. Again, a very important one. A 25-year-old man is diagnosed with a possibacillary leprosy. He's planned to start the WHO multi-drug therapy, MDT. The weight is 60 kgs and he has the normal renal and liver function test. Which of the following represents the correct daily dose of the dapsone for this patients? Now you already know we have leprosy, okay, Mycobacterium leprae, okay, followed by that we have hypoanesthetic paths with no sensation as well. Now we have two types. One is going to be the paucibacillary, one is going to be the multibacillary. Okay, now pauci and multi. So what exactly, how to differentiate? Very good. So first 1 to 5 lesions here more than 5 lesions. Okay, now sir, treatment for 6 months, treatment here is for 12 months. Okay, so nerve involvement here is 0, here is 1 or more than 1, 1 or more than 1. Again the three drugs, dapsone, clofazimine and rifampicin DCR. Here also dapsone, rifampicin and clofazimine. Is that clear? Now you already know this, how to differentiate a paucibacillary leprosy, how to differentiate a multibacillary leprosy. Now question was asked, dapsone ka dosage kitna hai? You know it is given 100 mg daily. It is given 100 mg daily. Again the previous equation bache. Now which nerve is involved? Agar nerve ki baat kare, which nerve is involved? That it is going to be the ulnar nerve which is involved in the leprosy. If they ask which cranial nerve is involved, your answer is going to be the facial nerve. Your answer is going to be the facial nerve. So paucibacillary and multibacillary. Clear? Now sir, if we talk about a pauci, again three drugs, dapsone, clofazimine and rifampicin. Okay, 6 months duration we have mentioned, and dapsone is given 100 mg daily. Along with that, rifampicin is giving 600 mg once a month. Okay, and clofazimine first we'll give 300 mg once a month, followed by that you have to give 50 mg daily. Okay, now talking about multi, 12 months duration, doses are exactly same. There is no difference in the dosage. The difference is in the duration. So remember, dapsone is 100 mg per day, rifampicin is 600 mg once a month, and clofazimine once 300 mg and followed by that 50 mg daily. Clear? One more question they have asked about the lepra reaction. Okay, now lepra reaction, you already know that lepra reaction may rule of 5. Type 1 lepra reaction, it is going to be the type 4 hypersensitivity reaction, and type 2 lepra reaction, it's going to be type 3 hypersensitivity reaction. Okay, and drug of choice for lepra reaction is going to be steroids, but we also use thalidomide. Okay, chale, next question bache. Let's move to the next question. In a hostel of 80 students, one boy developed varicella. Ab chicken box hua hai, one boy developed varicella. 5 students were immune. Okay, 20 nerve cases occurred within the incubation period. Calculate the secondary attack rate. Okay, now what exactly is a secondary attack rate? How exactly to calculate? So secondary attack rate, it is a number of secondary cases in single incubation period divided by total number of suspected people and multiplied by 100. Now sir, first of all, if we see, we have primary cases, we have secondary cases, okay, and we have suspected cases. So you have to break the formula. So primary cases, सबसे पहले किसको disease थी? One student, one boy. So we have one primary case. Then followed by that, the cases which are developed from the contact of the primary case. Okay, so later on, how many of them developed? 20. So secondary are 20 people. Okay, then how many are the suspected ones? The suspected ones are the people, ek to 80 minus 1, the primary one, and the minus 5 which are immunized. Okay, so sir, it is going to be the 74 as suspected, because ek to primary is already having a disease and 5 are immunized, which are 7, which we will subtract from the total cases. So suspected are 74. So what is going to be the formula? So number of secondary cases. How many were the secondary cases? 20. So it's going to be 20 divided by, so number of suspected cases, that is going to be 74 multiplied by 100. That is going to be 2000 divided by 74, which is almost equal to the 27%, which is equal to the 27%. Okay, so what exactly is the answer? Sir, it is going to be the 27%. Is that clear? Is that clear how to solve the secondary attack rate? Yes. तो आपको क्या करना है, पहले प्राइमरी केसेस देखो, सेकेंडरी देखो कितने हैं, फॉलोड बाय दैट सस्पेक्टेड देखो कितने हैं, एंड इम्यूनाइज्ड कितने हैं. सो सिंपल सर, इट इज गोइंग टू बी 20 divided by 74 multiplied by 100. So the secondary attack rate is 27%. The secondary attack rate is how much, bachche? It is 27%. Let's move to the next question, guys. In a village, there was an outbreak of influenza where 400 cases were detected. The total population of a village is 5,000, and the deaths reported in the last month were 100 deaths. And these 100 deaths were due to the influenza, 50 were due to the road traffic accident, and 10 were due to the floods, and 5 due to the sterility. Calculate the case fatality rate. Now you have to calculate the case fatality rate. Okay, now first of all, what exactly is the importance of this case fatality rate? So it tells me about the killing power of the disease. For example, if I say the case fatality rate of a disease is 100%, what does that mean? That means that if 10 people got this disease, 10 के 10 मर जाएंगे. For example, rabies. CFR is how much, बच्चे? 100%. Okay, now sir, how exactly to calculate? चलो, CFR is calculated as, what is the formula? It's a total death. It's a total deaths due to the disease divided by total cases of that particular disease multiplied by 100. Multiplied by 100. Okay, now it is equal to total deaths of the disease were 100 divided by total cases of that particular disease were 400 cases. That is going to be 400. Okay, multiplied by 100. So case fatality rate is going to be 25. Okay, case fatality rate is going to be 25. So what is the answer for this particular question, guys? It is simple, so it is 25%. It is 25%. Which disease have case fatality rate of 100%, guys? That is going to be rabies. That is going to be rabies. Now what exactly is the importance of this case fatality rate? So it tells me about the severity of disease. So it tells me about the killing power of the disease. It tells me about the virulence power of organism. That is all about the case fatality rate. That is all about the CFR. Now how to calculate, bachche? So you will see how many were the total deaths due to the particular disease and how many were the total cases of that particular disease. Even though here deaths are more, here 50 deaths due to the RTA, 10 due to the floods, but you're not gonna include those in the formula. Okay, it is just the death due to that particular disease. Okay, चले आगे बढ़ते हैं. A 70-year-old retired construction worker presents with a dyspnea and weight loss. He has a history of asbestos exposure. A chest X-ray shows that there is a pleural thickening and a mass in the lower lung zone. What is the most concerning diagnosis? What is going to be the most concerning diagnosis for this condition? What is going to be the most concerning diagnosis for this particular condition? Write down in the chat box. Yes, all clear, bache? So far, whatever topics we have discussed, everything is clear. Tell me what exactly is going to be the diagnosis. You have a patient, okay, coming to you. Very good, almost everyone is right. Somebody's option A. Yes, I know this is an asbestosis, but along with the asbestosis, it is mentioned that patient is having a weight loss and there is a mass in the lower lung zone, which signifies that there is a malignancy. So pleural thickening as well. It's a classical case of a mesothelioma. Very good. So it's a classical case of a mesothelioma. Now you already know that most common cancer, okay, most common cancer is going to be, most common one in asbestosis, it's going to be bronchiogenic carcinoma and most specific, it is going to be the mesothelioma. It is going to be the mesothelioma. Okay, chale, next one, sir, pneumoconiosis. Now what are these pneumoconiosis? We'll discuss, because one question also is coming from this particular topic as well. Now these are the respiratory diseases. So pneumoconiosis are respiratory disease which occur due to exposure to the dust, which occur due to exposure to dust. Okay, I will mention bache short whatever you remember about each of the following pneumoconiosis. Number first one, that is going to be silicosis. Silicosis में short, sir, it's the most common type. Number first one. Number second one, sir, it is related to the tuberculosis. That's why the follow-up for tuberculosis is for which pneumoconiosis? Your answer should be bache, silicosis. Number third one, sir, will remember, it is due to the stone dust or silica dust. Okay, followed by that, on chest x-ray, so we have a eggshell calcification, and we have snowstorm appearance. On chest x-ray we have snowstorm appearance and eggshell calcification. Is that clear? Yes, we cannot go in detail, guys. Okay, yes, so at the end, remember that silicosis, it's the most common type of pneumoconiosis. Number second, sir, these people are more prone to the tuberculosis, that is why follow-up for TB is needed. Number third one, sir, it's related to the stone dust or the silica dust. Followed by that, on chest x-ray we have a classical eggshell calcification. And followed by that we have snowstorm appearance. Guys, if question will be asked, I'll show you from the image. Yaad rakhna. Okay, do remember this, bache. This is classical snowstorm appearance. Okay, and followed by that, their calcification here, like eggshell. Okay, this eggshell calcification, this is all about the silicosis. Okay, chale. And also remember, it usually affects the upper lobes, है ना? कहाँ affect करता है? Upper lobes. बाकी everyone lower lobes. Okay, now asbestosis. Okay, it is only pneumoconiosis associated with the malignancy. Short में slash. Sir, it is related to the shipyard or shipbuilding industry. Okay, followed by that we have classical asbestos bodies called as ferruginous bodies. Followed by that we have mesothelioma as more specific cancer, and bronchogenic adenocarcinoma as most common cancer. Is that clear? Yes, and the marker for mesothelioma is calretenin. Remember this as well. And what are these ferruginous bodies? These guitar-shaped bodies or table tennis bat-like bodies. These are the ferruginous bodies. And again, this has been the question asked in NEET PG 2024. This picture was given. Your answer is asbestosis. Is that clear? Yes. चले आगे बढ़ते. Next one is going to be the bisonosis. About the bisonosis, you already remember, sir, it's a cotton dust. It is a cotton dust slash, sir, it is going to be the textile industry. Slash, so it is going to be the associated with Monday chest tightness. Clear? So you already know in the short form, Monday chest tightness. Popcorn calcification in pulmonary hematoma. Yes, popcorn calcification is seen in the pulmonary hematoma, and pulmonary hematoma is going to be the most common benign tumor of lungs. Okay, so pulmonary hematoma with a popcorn calcification, but eggshell is with the silicosis. ठीक है ना? चलो आगे बढ़ते. Now followed by that, we have a bag of sauces. Sir, bag of sauces mein you have a sugar cane dust. You have a sugar cane dust. Followed by that, in bag of sauces, you can also remember, sir, we have a fungus, or you can write thermoactinomycetes. Okay, and prevention is with the 2% propionic acid, and you can write the industry as a cardboard industry. Add the cardboard industry. Okay, followed by that, we have anthracosis. You will remember the coal dust. You will remember the coal dust. And if there is a anthracosis along with the rheumatoid arthritis, okay, we have the classical syndrome called as Kaplan syndrome. Okay, what is that? So that is anthracosis plus rheumatoid arthritis, which is also called as rheumatomycosis, Then followed by that, we have berylliosis, and berylliosis is people who are working in a ship building industry, not shipbuilding. We have berylliosis, airspace industries. We have airspace industries. Okay, and then we have also farmer's lung or moldy hay related to the grain husk. Okay, then we have also siderosis related to the exposure to the iron dust, all other pneumoconiosis as well. But do remember all the ones we have discussed. We have asbestosis. Okay, remember that, sir, the silicosis is with upper lobes. Followed by that, we have asbestosis, we have basinosis, bagastosis, anthracosis, and berylliosis. Okay, is that clear? Is that clear to everyone? Yes. चलिए आगे बढ़ते हैं. A 26-year male presented with a fever, chills, night sweats, and diarrhea. The physician is suspecting the malaria, and he sent a blood sample for the diagnosis, and dipstick tests were performed for the rapid diagnosis of Plasmodium falciparum. It's based upon the which protein? It's based upon the which protein? Tell me, it's based upon the which protein? Very good. It is histidine rich protein. It is a histidine rich protein. Now tell me, sir, in the rapid diagnostic test, we have two tests. One is going to be the HRP antigen detection, that is histidine rich protein. Another one is going to be the LDH. Can you tell me what exactly is the difference between the two tests? What exactly is the difference between these two tests? Number one is histidine rich protein, and number second is the lactate dehydrogenase. What exactly is the difference? Sir, the histidine rich protein can only detect the falciparum, okay, while as LDH can detect falciparum as well as the Plasmodium vivax, okay. Now malaria being the very important one, remember the agent is Plasmodium falciparum. Okay, along with that, it can be ovale, it can be vivax, it can be malariae, or it can be novelaceae as well. Okay, now sir, talking about the diagnosis, the investigation of choice is going to be the peripheral blood smear. The investigation of choice is going to be peripheral blood smear. Now this peripheral blood smear, okay, we are taking two peripheral blood smear. Okay, now one is going to be the thin, one is going to be the thick. One is going to be thin, one is going to be thick. Now about the thin, sir, it will tell me about species of malaria. It will tell me about species of malaria. And about the thick one, it will tell me about the confirmation of disease. It will tell me about the confirmation of malaria. Okay, followed by that, sir, who is going to take this smear? It is taken by multi-purpose worker male at PHC. Okay, so two blood smears, one is thin, one is thick. Thin is for to know the type, species involved, and well as thick is for the confirmation of the disease. And for the rapid diagnostic kit, we are going for HRP. What is that? Histidine rich protein. And we are going for LDH, lactate dehydrogenase. Okay, now HRP can only detect the falciparum, while as LDH can detect falciparum plus Vivx. Is that clear? That is the first question. Next question that they can ask, what is the treatment that they usually ask? Now, sir, depending upon the northeastern and the other states. Okay, one rule you will remember. Okay, one thing you will remember, whenever examiner will ask the question about the Plasmodium vivax. Okay, treatment. Whenever an examiner will ask the question related to the Plasmodium vivax, there is only one answer. Okay, what is the answer, bache? There is only one answer, that is going to be chloroquine. The drug is chloroquine in all states. In all states. So anytime the examiner will ask the question that what exactly is the treatment for a patient from northeastern states having Plasmodium vivax malaria, your answer is going to be, what is the answer, bache? Answer is going to be the chloroquine. Now, sir, if falciparum, your answer is going to be ACTL. What is ACTL? We have artemether. Followed by that, we have lumefantrine. Followed by that, we have primaquine. We have primaquine. Then in other states, we have ACTSP. What is ACTSP? We have artesunate. We have sulfadoxine. And we have primaquine. And we have primaquine. So that is going to be the treatment for malaria with Plasmodium falciparum. Okay, आगे बढ़ते. Now, sir, what exactly will be the treatment in case of a malaria with a pregnancy? Malaria with a pregnancy. Okay. Now, sir, in pregnancy, if we have a Plasmodium vivax, if we have a Plasmodium vivax, we have chloroquine for all trimesters. We have chloroquine for all trimesters. And if it is Plasmodium falciparum, then the treatment for the first trimester is going to be, what is the treatment for the first trimester in falciparum? Sir, it is going to be the quinine. And sir, second and third trimester, if northeastern state, it is going to be ACTL. Okay, if northeastern state, it is going to be ACTL. If other states, it is going to be ACTSP. It is going to be ACTSP. Is that clear? So ACTL and ACTSP. Now, what exactly can be the prophylactic drugs you start for the malaria? Sir, if short term, that is less than 6 weeks travel, we give a drug that is doxycycline. We go with a doxycycline. Sir, if long term, that means the travel is more than 6 weeks, so we go a drug called as mefloquine. तो क्या देंगे? Mefloquine. Now, how exactly to give? If there's a short term, we are giving 3 to 4 days prior to the travel and 2 to 3 weeks post travel. And if it's a long term, we give 2 to 3 weeks prior to the travel and also 3 to 4 weeks post travel. So that's all about the malaria. Remember, for a short term prophylaxis, we are giving doxycycline. For a long term prophylaxis, we are going to give mefloquine. Let's move to the next question, guys. A 32-year-old female, para 3, live 3, visits a gynecology OPD for the contraception. On examinations, you have noticed there's a foul smelling vaginal discharge. Which of these following contraceptive method is relatively contraindicated in this case? Okay. Now, sir, which contraception is contraindicated in a case a patient is coming with a contraception for the contraception advice, but you are seeing that there is a false swelling discharge, which is a classical case of a PID. So PID, which particular contraception is contraindicated? Tell me, in PID, which particular contraception is contraindicated? Which particular Very good. So that is going to be intrauterine device. That is going to be the intrauterine device. Okay. Now let's discuss about the contraindications. So in contraindications, we have absolute contraindications and we have relative contraindications. Okay. Now, what are the absolute contraindications for the intrauterine contraceptive device? We have number first one is, sir, if we are suspecting a pregnancy. So a suspected pregnancy is going to be an absolute contraindication. Followed by that, if a patient is having undiagnosed bleeding per vaginal, if there is an undiagnosed bleeding per vaginal, it is going to be the absolute contraindication. Followed by that, if a patient is having a current PID, again it's going to be an absolute contraindication, or a patient with a polyp or a cervical cancer or a polyp. This is all about the absolute contraindication. This is all about the absolute contraindications. Is that clear? Yes. Now what can be the relative contraindication, sir? What can be the relative contraindication? Number first relative contraindication, as you know, the side effect of this IUCD is what? What exactly is the side effect of the IUCD? Menorrhagia or polymenorrhea, increased menstrual bleeding. So if a patient is already having anemia, okay, so this is going to be the relative contraindication. Or a patient with a fibroid, it is going to be the relative contraindication. If a patient is having a history of ectopic pregnancy, okay, if a patient is having a history of PID, okay, all these are going to be the relative contraindication. Followed by that, what else can be the contraindication relative? If a patient is having a uterine malformation, okay, malformation of the uterus, that is bicornuate uterus, okay, or septate uterus, or some Mullerian defects, malformation of the uterus, that is going to be a relative contraindication. Or a patient is having the history of multiple partners, because the most common reason of removal of the ICD is what? That is going to be the infection, pain. So people with the multiple sexual partners is again going to be the relative contraindication. Is that clear? Is that clear to everyone? Yes. Now, sir, if a patient is coming to you, after IUCD, intrauterine contraceptive device, patient is complaining of heavy bleeding. Write down in the chat box what is going to be the answer. What is going to be the answer for that patient? What you are going to do, sir? If a patient is coming with a heavy menstrual bleeding after the IUCD insertion, I am going to give a reassurance. Plus, you are giving folic acid and iron. Is that clear? But if a same patient will complain, second scenario, after IUCD, patient is having pain, and pain is due to the infection. So what we are going to do? So remove and start antibiotics. Remove and start antibiotics. Okay. Again, one question. If For the removal of the IUCD, it is found in uterus. You remove with a hysteroscopy. Outside the uterus, you remove with the laparoscopy. So hysteroscopy inside the uterus, outside the uterus, it is laparoscopy. Chale. Next question. Physical quality of life includes. Now, indicators of a life. We have PQLI, physical quality of life index, and human development index. So PQLI includes all of the following parameters except PQLI includes all of the following parameters except. What will be the answer? PQLI includes the following parameters except. Yes, that is going to be life expectancy at birth. Very good. That is going to be life expectancy at birth. Okay. Good. Okay. Chale. Infant mortality, sir, it is a feature of PQLI, component of a PQLI. Life expectancy at one age, again PQLI. Education or mean year of schooling, again that is going to be PQLI. Okay. Life expectancy at birth, it is going to be HDI, Human Development Index. Okay. Now, sir, what are the components? So the components of a PQLI. The first one, it is life expectancy. It is life expectancy at 1 year of age. Followed by that, we are going to have a literacy rate. Followed by that, we have infant mortality rate. We have infant mortality rate. Okay, and the range is 0 to 100. Range for this is going to be 0 to 100. Okay, what are the components of an HDI, Human Development Index? So it is going to be life expectancy at birth. It is life expectancy at birth. Followed by that, we have the knowledge. And followed by that, we have income. So this income, knowledge, and life expectancy at birth, these three components are for the Human Development Index. Okay, and for that, range is equal to 0 to 1. Range is equal to 0 to 1. Okay, now we have a different names related to the literacy rate. So if they mention the synonyms of the literacy rate, remember that. So rather mentioning the literacy rate, the examiner can mention, okay, what? He can mention knowledge. He can mention the mean year of schooling. Mean year of schooling. Or he can mention the education index. Or he can mention the education index. So remember, okay. So all those criterias. Number first one, in PQLI, we have life expectancy at 1 year. We have literacy rate and infant mortality rate. And in HDI, life expectancy at birth, knowledge, and income. Okay, and in NEET PG, the same question was asked, but not in a that simpler manner. They have mentioned which of the following includes the, which of the following defines the HDI. So they have mentioned the options like with the same ABC, BCA, DCA. So you have to remember the three components. You have to remember the three components. So first, so life expectancy at 1 year of age. Okay, literacy rate and infant mortality rate. That all is with a PQLI. So life expectancy at birth. Okay, HDI. At birth, knowledge, and along with that, income. So that is going to be with the Human Developmental Index. Okay, let's move to the next question, guys. What is the recommended vaccination schedule for post-exposure prophylaxis of rabies in previously vaccinated individual? So you have a patient coming to you. He had a dog bite. Along with that, he's saying that, sir, I was already vaccinated 6 months back. I was already vaccinated 6 months back. So what will be your rabies schedule for this particular patient? Write down in the chat box. So you have this patient coming to you. Yes, patient got a dog bite. Okay, and now he's saying that he was already vaccinated 6 months back. Now we have three clinical scenarios in a patient after the rabies, or after the dog bite. Okay, now talking about the dog bite first, we have three grades. Grade 1, that the dog is having just a licking on the impacted skin. Grade 2, there are multiple abrasions or the scratch. And grade 3, there is a bite with the bleeding coming out. So grade 1 licking, grade 2 scratch, grade 3 a proper wound is there. Okay, and so now before the bite, if a patient is coming now, a person is coming, he has a dog back home and he's saying, sir, I want a pre-exposure prophylaxis. So he's coming before bite. ऐसे याद रखो, before bite. Now before bite, if he's coming, how many doses you are giving? How many doses you are giving, bache? Yes, before the bite I'm going to give 3 doses. How many doses? I'm going to give 3 doses. Now what exactly are these 3 doses? Sir, we are giving a doses on day 0, day 7, or booster dose on 21 or 28. Booster dose on 21 or 28. That is going to be the pre-exposure prophylaxis. Now sir, post-exposure prophylaxis, not vaccinated at all. Now if a patient is not vaccinated at all, that means after the bite. Now after the bite we have two scenarios. Now either a patient is vaccinated or either the patient is not vaccinated. Now, if a patient is not vaccinated, we have two regimes. If we talk about intramuscular regime, SN regime, we are going to give 5 doses. What exactly are the dates? 0, 3, 7, 14, and 28. Okay. Followed by that, if we are going with the intradermal regime, that is going to be Thai Red Cross regime. And sir, the doses are 0, 3, 7, skipping the 14 and giving on 28. That is a post-exposure prophylaxis in a patient, intradermal, not vaccinated. Now, post-exposure prophylaxis in a patient who is vaccinated. Now, this guy, he was already vaccinated. Now, again, two scenarios. If less than 3 months, अगर 3 महीने पहले he was vaccinated, then sir, no intervention, nothing to be done. Nothing to be done. Okay, and sir, if the same patient is having a vaccination 3 months ago, more than 3 months ago, then we are only giving 2 doses, that is 0 and 3. That is only 2 doses, 0 and 3. Is that clear? Is that clear to everyone? Yes. Is that clear to everyone? So here we have 2 doses, here we have 5 doses, here we have 4 doses, and above we have 3 doses. That's all about the rabies pre-exposure and post-exposure prophylaxis. Now the virus responsible for the rabies, you already know the name of the virus is a Lissa virus. Okay, it has case fatality rate of 100%. Followed by that we have a classical bodies, intracytoplasmic inclusion bodies called as Negri bodies, and these Negri bodies are first found in the hippocampus, and second site to be found is the cerebellum. Followed by that the motor protein which is responsible in the rabies. Okay, what is the name of the motor protein? That is dynein. That is going to be dynein. Okay, and also from the micro, you know that it is a bullet shaped virus. So here a patient is coming to you for the post exposure prophylaxis and he was already vaccinated. So then the answer is going to be wound cleaning plus ARV on day 0 and 3. Okay, and along with that in grade 3 dog bite we are also giving the rabies immunoglobulin, 40 international units per kg, 40 international units per kg. So that's all about the rabies. Okay, we can also give the rig, 40 international units per kg. Is that clear? Everything about the rabies is clear. So make sure you see, is the patient vaccinated or is a patient not vaccinated? And if a patient is vaccinated, is it within 3 months or more than 3 months? If within 3 months, nothing to be done. More than 3 months, we have to go for 2 doses, 0 and 3. 0 and 3. Chale, next question. A study was conducted to assess the association between the smoking and the lung cancer. The following data was collected. Now we have patients, we have lung cancer patients, and we have the patients having a disease and patients who have not disease. Okay, now the data is not here, but I remember the data myself. It is 60 people had a lung cancer patient, and lung cancer was absent in 40 people, and the total cases were 100 cases. And non-smokers were total with the disease present were 20, disease absent is 80, and again they were the 100 people. Okay, now sir, let's discuss what exactly is the relative risk. Okay, now if you remember from the epidemiological studies, we have 4 studies. A quick recap: so we have a cohort study, which is a forward looking study, which is a prospective study, which goes from a risk factor to the disease, or which goes from the cause to the effect. Okay, and now sir, about this disease, it's a very slow because you need a continuous follow-up. You're waiting for a disease to occur, and sir, it's very expensive as you have to follow up. Along with that, you have to go with the investigations and all. And sir, the strength of association for that particular disease is given by the relative risk, attributable risk, population attributable risk, right? Now here we are having a study to assess what exactly is the association between the smoking and the lung cancer. So we are going in a forward direction, right? So relative risk is calculated in which type of study? It is a cohort study. Then we have discussed the case control as well. It is exactly the opposite of the cohort study, that is a case control study. Okay, so it is backward. If that is a prospective, it's a retrospective. Okay, it's fast. Okay, and it's not expensive, and the strength of association is given by the odds ratio. Okay, then we have a cross-sectional study in which we can calculate the prevalence. It's neither forward nor backward, it's at a point. And then followed by that, we have an ecological study which tells us about the characteristic of the population. Clear? Now sir, talking about this particular formula, that what exactly is a relative risk. Now relative risk is an association between the incidence in exposed while non-exposed. So it is incidence in exposed divided by incidence in non-exposed. Now what exactly will this will tell me? Okay, now sir, whenever we are talking about a relative risk, for example, I have 10 people, okay, who are smokers and 10 people who are not smokers. Now the study that I'm going to do among these 2 groups is the lung cancer. Okay, now I'm seeing that the people who are consuming or who are smoking, they have more chances of developing the lung cancer compared to the people who are non-smokers. So when I do an study between them, the study is a cohort study, and the strength of association, whether that risk factor is involved to the disease or not, that is given by the relative risk. So the formula is, we have the incidence in exposed and incidence in non-exposed. Now talking about incidence in exposed, now incidence in exposed is equal to, so how many cancer patients were there? 60 people among 100 people, that is going to be 0.6. Incidence in non-exposed people, so we had 20 people lung disease among 100 people. So that is going to be 0.2. Now 0.6 by 0.2, that is 3. So what is the answer, bache, for this question? So the answer is 3. So can I say that the risk of the smoking is 3 times more in people who are smokers. The risk of a lung cancer, is 3 times more than people who are smokers compared to the non-smokers. So that is all about what? Relative risk. And relative risk is calculated in which study? It is cohort study. Remember, if we talk about the unit of study among the cohort, case control and cross-sectional study, it is going to be the individual, while as if we talk about ecological study, the unit of study is going to be the population, because ecological study will tell me about the characteristic of the population. That's going to tell me about the characteristic of population. Clear to everyone? Yes, about the relative risk. Okay, then the interpretation of the relative risk. Yes, if it is more than 1, that means there is an association of the risk factor. So in this particular question, the answer was 3. More than 1, that means yes, smoking is related to the lung cancer. Smoking is related to the lung cancer. Let's move to the next final part. We'll discuss about the disease and the agents and their vectors. Okay, now whatever you know about this disease, let's speak it out so that it will be a quick recap from the micro end as well. Okay, it's a short 2 hour session. That's why most of the repeated topics that have been asked in your exam I've included. But yes, there is some demographic indicators update. Okay, I will discuss that as well. What are the current CBR, CDR, and new MMR and all those values. Followed by that, please go through the sensitivity, specificity. Okay, go through the PHC norms. Okay, go through the ASHA, village workers, and all these questions that I've discussed also on the YouTube as well. Make sure you watch that video as well so that it will be beneficial. Okay, for the 2 hours, whatever possible, whatever topics I would have discussed, I've already discussed that as well. So let's talk about the first disease, that is going to be the brucellosis. Now, what exactly is the agent for the brucellosis? It is B. melitensis. It is B. melitensis. Okay, so whenever we talk about the brucellosis, sir, the vector is unpasteurized milk. The vector is unpasteurized milk. That is why the pasteurization, disinfection process of the milk is very, very important. Okay, now, sir, if we talk about the brucellosis, we have a classical complaint of the patient. That patient is going to have a swinging fever. पहली बात याद रखना. Second, we have two tests. One is going to be Rose Bengal test. Another one is milk ring test. So Rose Bengal test and milk ring test is done in case of brucellosis. The swinging fever is seen in case of a brucellosis, and the drug of choice for this brucellosis is going to be the doxycycline. It is going to be the doxycycline. Next one, it's KFD. The agent for KFD, it is going to be group B arbovirus. It's going to be group B arbovirus. Sure, I will discuss also paired and unpaired. Okay, no problem. I will discuss whatever I can. Whatever things you want me to discuss, I will discuss that as well. Koi baat nahi hai, but let's focus on this point for now. Okay, and the vector is going to be hard tick. Vector is going to be the hard tick. Followed by that, yellow fever. Again, sir, group B arbovirus for the yellow fever. And sir, the vector is going to be the Aedes mosquito. The vector is going to be the Aedes mosquito. Okay, then followed by that we have leptospirosis. So the agent is L. interrogans. Okay, remember what can be the clinical features of the leptospirosis? Conjunctivitis, okay, renal failure and all. Followed by that, what can be the vector? It is a rat urine. It is rat urine. Okay, we'll check the leptospirin in blood and urine as an investigation, and for normal moderate cases, drug of choice is doxy, and severe cases we are giving penicillin as well. Okay, then echinococcus. Okay, the agent is going to be echinococcus granulosus. Okay, followed by that the vector is going to be dog. Okay, now you already know that echinococcus granulosus, it causes the hydrated cyst of the liver, more precisely to be the round right lobe of the liver. And then the technique we have, the treatment is pair therapy. P for puncture, A aspiration, I initiating this qualitical agent like albendazole, which will shrink the size of the cyst, and R is re-aspiration. Remember that. Followed by that we have teniasis. Okay, we have Taenia solium and Taenia saginata. About this, you already know they can cause the neurocysticercosis or the teniasis. Neurocysticercosis, you already remember that neurocysticercosis, it's a starry sky appearance on MRI. Followed by that, sir, drug of choice is going to be albendazole and steroids. Okay, and for the teniasis, the drug of choice is going to be the niclosamide and praziquantel. And for that, we have pork and beef. We have pork and beef. Then plague, we have Yersinia pestis. Yersinia pestis. Then we have most common type of bubonic plague, but the most dangerous and the severe is a pneumonic plague. And for the plague, the prophylactic drug that we use is tetracyclines, and the drug of choice is going to be the streptomycin. Okay, and for the plague, what is the vector? That is going to be rat flea. That is going to be rat flea. Okay, followed by that we have malaria. The agent in the malaria is a plasmodium species. You already know whether it's a falciparum, malariae and all, vivax and ovale. The vector is going to be Anopheles female. The vector is going to be Anopheles female. Okay, followed by that rabies. The agent is Lissa virus, I've just discussed, and the vector is going to be the rabid animal. Okay, na? Followed by that, we have dengue. Again, the dengue, we have group B arbovirus. Okay, it's also called as breakbone fever. Okay, and one more important thing is that in dengue we have undifferentiated fever, but swinging fever in brucellosis, step ladder fever in the typhoid. Okay, and followed by that dengue, along with that patient will have a bone pain, arthalgia, myalgia, and all. The first investigation we are going with the NS1 antigen within the first 5 days of fever. Then followed by that we can go with the ELISA IgM, and then the mainstay of treatment is going to be fluids, because we have to stop the complications for the hemorrhagic fever and dengue shock syndrome. Okay, now what can be the vector? What will be the vector? That is Aedes mosquito. That is Aedes mosquito. Okay, followed by that epidemic typhus we have. It's Rickettsia prowazaki. It's Rickettsia prowazaki, and sir, the vector is louse bite. Okay, followed by that we have endemic typhus. We have Rickettsia typhi, and sir, the vector is flea. Followed by that we have scrub typhus. We have Rickettsia sutsugumoshi, and we have mite as a vector. Followed by that we have rickettsial fevers, Rocky Mountain spotted fever. We have Rickettsia rickettsii, and vector is going to be hard tick. Rocks are hard, so remember vector is hard tick. Indian tick typhus, remember also India is hard. Rickettsia coroni, again hard tick. And Rickettsia pox, the agent is Rickettsia acari, and the vector is going to be mite. So this is all about all the disease agents and vectors. Is that clear? Yes. Now sir, somebody asked, sir, please tell me about paired, unpaired, and cheese cat test. Let me discuss somewhere we have space. चलो यहाँ पे let me discuss here. Is that clear? Now bache, whenever we talk about a data, okay, these are called the test of significance. Okay, now sir, in tests of significance we have a quantitative data bache, and we have a qualitative data. Okay, we have a qualitative data and quantitative data. What is quantitative data? The data that you can measure, the data that the measurement is possible. Okay, what is qualitative data? Measurement is not possible. Okay, measurement is not possible. Okay, now for example, if you are taking a blood pressure, are you getting my point? Is blood pressure a quantitative data or a qualitative data? Tell me. Is yes, I will show you the questions as well. Pehle samajh to lo what exactly is that test. Okay, now sir, whenever we talk about a qualitative data and a quantitative data, the qualitative data means that the measurement is possible. What is qualitative data? Measurement is not possible. So quantitative mein I can measure the things, for example blood pressure, for example cholesterol levels. Are you getting my point? But in qualitative data I cannot measure, for example anemia. Can I measure the anemia? No. I can know the type of the anemia, है ना? Disease, either disease is present or disease is absent. Okay, RH factor. Okay, now sir, for example, now we have a group. Okay, it's coming up, 5 people are coming up in the group. Okay, and I'm going to check the cholesterol level of this particular group. Okay, and I'm seeing that the cholesterol level comes 300. Okay, now it's more than 200, it's more than normal. Now sir, the first thing I'm doing with these 5 people, the one group, I'm telling them you start a drug statins. तो मैं कौन सी दवाई start कर रहा हूँ? Statins. These are the hypolipidemic drugs. Okay, I'm starting the atorvastatin. Drug or rosuvastatin drug, and I'm telling them after 1 month come back to me, and I am going to check again the cholesterol levels of these 5 people, that one particular group. So before the intervention and after the intervention, when you have a same group, when you have a one group, okay, in terms of a quantitative data, the type of a test or the test of significance that we use is a paired student t-test. Again, I will repeat. Okay, first of all, whenever such question will come, my dear students, you are going to check whether the data is quantitative or qualitative. Now, what is quantitative data? In which the measurement is possible. Okay, now you are saying that blood pressure or cholesterol levels of this particular group, one group A, is 300. Now, sir, after 1 month, I'm again comparing the cholesterol levels of the same group. Okay, पहले मैंने इनको दवाई दे दी, I gave them a atorvastatin drug, and then again after 1 month they are coming back. Again I'm checking the levels. So before the intervention and after the intervention, I'm comparing the cholesterol level of a same group. The type of the test I'm using is paired student t-test. What is the test, bache? Paired student t-test. Okay, now next one. There are two groups, group A and group B. What are the two groups? Group A and group B. Now, both of them have high cholesterol levels. Now, one group I'm giving atorvastatin. Second group I'm telling go for the lifestyle modifications. Have a brisk walk, no sugar, diet modification and all. So when you are comparing between two groups, the test you are going to use is unpaired student t-test. Are you understanding my point? One group हो गया तो paired student t-test, two groups हो गया unpaired student t-test, and more than two groups if we have, the test is going to be ANOVA test. The test is going to be ANOVA test. Again, so first of all, I'm going to check the type of data. That if it is a quantitative data, I have three main tests. So the test I have is paired student t-test for the one group, unpaired for the two groups, more than two groups, I have ANOVA test. Okay, now look out the question. How examiner will ask first for which particular condition? Quantitative data. I will show you the question. Just a second. Look at the question, guys. A blood pressure of three different groups A, B and C was measured, and the mean blood pressure calculated out of it. The three means are different. The most appropriate test to determine the difference between the mean is, okay, difference between the mean is, now I have a blood pressure, it's a quantitative or qualitative? Sir, it is going to be the quantitative. Okay, sir, measurement is possible. I'll go with the parametric test. Okay, and sir, when we have more than two groups in a quantitative data, the test that I am going to use, what is the answer for this particular test? क्या कौन सा test हम use करेंगे? Sir, it is going to be ANOVA test. It is going to be ANOVA test. Is that clear? Is that clear? Yes, very good. Okay, I'll show you one more question now. I'm not giving the options. Okay, you just tell me the answer. A cardiologist wants to study the effect of an atorvastatin drug. He notes down the initial cholesterol levels of 50 patients. He administers the drug, and after the month treatment, he measures the cholesterol level again of the same 50 people. What is going to be the test of significance for them? What is going to be the test of significance for these people? Before an intervention, after the intervention, the same group. What exactly is your answer? What exactly is your answer? I'm not giving options for this particular question. This is a cholesterol level you can measure, and before and after there is a one same group. The answer is going to be very good. When before an intervention and after the intervention you have same group, the answer is going to be the paired student t-test. Very good. What's the answer? It is going to be paired student t-test. Is that clear? One more. Chale, one more I will show you guys. One more I can show you fast. Look at this question, bache. A study is undertaken to determine whether drinking more than 10 cups of a coffee a day is associated with hypertension or not. The blood pressure readings were taken of the person who drinks 8 cups and a person who drinks no coffee. So One group is people who are having coffee. One is people who are not having coffee. Now I have to see the relation of a coffee and a hypertension between them. Now the result is follow. Which of the following test you will use? Final question for this one. Which of the following test you will use? Hypertension है, coffee है, दो groups है. What is going to be the answer? Why you guys are, some people are mentioning A. मैंने तो G square अभी पढ़ाया ही नहीं. I have not discussed G square yet. I have just told either paired, unpaired or ANOVA. I will come there as well, but that is qualitative part. I am talking about quantitative part. Very good. Two groups. It is going to be unpaired student t-test. It is going to be students unpaired t-test. Is that clear? Is that clear to everyone? It's clear to everyone? Yes. Now look at this. So whenever we are talking about a quantitative data, are you getting my point? So we have two tests. Either we have student t-test or we have ANOVA test. So if we have a one group in our quantitative data, the answer is going to be the paired student test. If two groups, answer is going to be the unpaired student. If more than two groups, answer is going to be the ANOVA test. Is that clear? Is that clear? Are you getting my point? Now, sir, next is qualitative data. The measurement is not possible, so we are taking percentage and proportion. So these are the non-parametric tests. And now, if I talk about a one paired group in a qualitative data where the measurement is not possible, the answer is the sign test. And two or more than two groups in a qualitative data, in order to go for a percentage or proportion where the measurement is not possible, उसके लिए हम करते हैं chi square test. Are you getting my point? One exactly you have to go for a chi square test, and one exactly you have to go for a unpaired, paired, and ANOVA test. So simple question. I'm not giving the options. You will answer me this. What is the test of significance which is done for two or more two proportions? In quantitative data, we talked about mean and standard deviation, but in qualitative, percentage and proportion. So if you have two or more than two proportions, what exactly will be the test now? कौन सा test होगा? What exactly will be the test now? For two or more than two proportions, the test is going to be chi square test or chi square test. Are you getting my point? Yes. Now I'm talking about percentage and proportions. So answer is going to be chi square test. Is that clear now? Test of significance is clear now? Yes. So सबसे पहले देखना है whether the data is quantitative or qualitative, and then further you have to go. If it is quantitative, one group, it is paired. Two groups, it's unpaired. More than two groups, it is ANOVA. If it is one paired group in qualitative, it is sign test. Two or more than two, it is going to be chi square test. Parametric test, we have first three. Non-parametric, next two. Is that clear? Yes. Now, sir, so that's what we have mentioned over here, guys. We have tests of significance, quantitative and qualitative data first. That's it. Okay, all clear now? Can you solve the question? Just see the comparison. Okay, just see the comparison. For a quantitative data, among one group is going to be the same group is going to be the paired, two groups is going to be unpaired, three groups is going to be more than two is going to be ANOVA test. Okay, chalo, write down the updated this demographic indicators. I will write here. Okay, they can ask this bache. Now new CBR is 18.4, new CDR, that is 6.4, new maternal mortality ratio, it is 83. Before it was 93, now it is 83. Okay, now infant mortality rate, it's 25. Okay, now sir, maternal mortality ratio and rate, what is the difference? In ratio, the denominator is live births. In rate, the denominator is women of reproductive age. Okay, and what will be the annual growth? You already know how to calculate annual growth. It is CBR minus CDR divided by 10. So it is going to be again the question was asked, it is 18.4 minus 6.4 divided by 10. That is going to be 12 divided by 10, that is 1.2. So annual growth is how much? 1.2. So remember, this is a neonatal mortality rate, NMR. It is going to be 19. This is all per 1000 live births, except the MMR. It is per 1 lakh live births. Yes, it is per 1000. Rest is per 1000. Is that clear? And total fertility rate also, that is going to be 1.9. That is going to be 1.9. Sex ratio, we have also 917. 917 females per 1000 males. That is all about the update. That is all about the demographic updates. So rest, guys, be confident. This was all. Still, if you have any doubts, you can ping me up in the Telegram, but your doubt should be study related. Okay, it was a short section, crisp and concise. We cannot go through all the topics, okay, but we have done the revisions multiple times this session. Okay, you can watch those videos full. Okay, we had a complete 1 day full revision of 9 hours. Okay, so all the possible questions, at least it will be a beneficial in these 2 hours. Okay, so all the best. Be confident you have studied enough. Okay, and make sure that every question you will go, you are going to read it twice. Okay, every single question. Don't be overconfident. Avoid the silly mistakes as well. Okay, and get it done. Okay, and we are going to start a new batch very soon. Followed by that, the notifications will be shared on the NLC Telegram group and the YouTube as well. But eventually it's not for the you guys, because you guys are going to pass this exam for sure. Are you getting my point? So make sure whatever you have studied, be confident enough, and please make sure that either we win or we learn. We never lose. Okay, whatever you will solve, whatever you will write, whatever option you will mark, be fully confident, because one single question can decide either you're going to be a doctor or either you're going to be a repeater. Okay, you have studied enough. No need to compare yourself with anyone. Okay,